Hi guys, welcome back. So firstly, I want to apologize. I look really scruffy today. Literally just got home from the gym, but I want to record this quick video talking about acute stroke. So this is the final topic in the clinical skills module. So let's first define what stroke is. So stroke is when blood flow to a particular part of the brain stops. And this can be due to two main mechanisms. So the first one can be due to a blockage in the vessel supplying that particular part of the brain with oxygen and nutrients. So this is called ischemic stroke, and this is actually the most common type of stroke. And the second method that this can happen is when a blood vessel ruptures in the brain. So this is called haemorrhagic stroke. Let's first discuss ischemic stroke. So like I said, this is the most common type, and this happens due to the obstruction of an artery supplying a particular part of the brain with nutrients and the blood and the oxygen that it needs. So this can happen by two different methods. So in terms of types of obstruction, so firstly we can get like an embolus being lodged in that artery. So an embolus is like a blood clot or a plaque fragment from a different part of the body getting stuck or getting lodged in that vessel and therefore obstructing the flow of blood. The second way we can get ischemic stroke is when a thrombus forms inside that vessel itself. So a thrombus is like a blood clot or a plaque that builds inside that vessel that doesn't originate anywhere else in the body. So that then obstructs the flow of blood in that particular part of the brain, leading to an ischemic stroke. Hemorrhagic stroke, on the other hand, can be a result of trauma or a ruptured aneurysm. And again, there's two types depending on the location of the bleed. So the first type of hemorrhagic stroke is intraparenchymal, which is also called intracerebral hemorrhage. So this is bleeding directly into the brain tissue itself. The second type is subarachnoid hemorrhage. So this is bleeding into the subarachnoid space. So like I said, ischemic stroke is the most common. I think it accounts for 87% of strokes, and then followed by the intraparenchymal or intracerebral type, and then subarachnoid is the least common type. Let's discuss some of the controllable risk factors that can lead to stroke. So firstly, we have hypertension or high blood pressure. So blood pressures over 140/90 can damage the arteries supplying blood to the brain. The second risk factor is high cholesterol in the blood, because high cholesterol in the blood can contribute to plaque buildup. And then we also have lack of physical activity, obesity. Smoking is a big one. So smoking doubles the risk of getting an ischemic stroke. Also, excessive alcohol use. So more than 2 drinks per day increases your blood pressure, and binge drinking may lead to stroke. So we also have the use of birth control pills and having heart diseases, especially abnormal heart rhythms like atrial fibrillation. Also diabetes. People with diabetes are at a greater risk of having stroke than those without diabetes. Now let's briefly go over some of the non-controllable risk factors for stroke. So firstly, we have age. So for each decade after the age of 55, the risk for having a stroke actually doubles. The second one is race. So African Americans are at a much higher risk of getting stroke. This is due to the higher, compared to whites, and this is due to the higher incidence of hypertension in that population. The third one is gender. Stroke actually occurs more often in males, but more females die from this. The fourth one is having a history of previous stroke. So you're more likely to have another stroke if you've already had one previously. And finally, your genetics. So the chance of stroke is much higher in those people with family history of stroke. Now let's talk about the signs of stroke. So we use the FAST method to detect any signs of stroke. So FAST stands for face, arm, speech, and T for time. So the first one is facial droop. So if the face of the patient on one side seems like it's drooping, or it feels weak or numb for the patient, then that might be indicative of a stroke. So what we can do to assess this is we can ask the patient to smile. And what we look for is, obviously, the normal would be both sides would move equally. And the abnormal is one side wouldn't move as well as the other side. A is for arm weakness. So what we can do is we can ask the patient to lift, so extend both of their arms right in front of them, straight out with palms facing up. And if one side doesn't move as well as the other, or if one side drifts down as the patient is trying to elevate both arms, then that's a positive sign for the arm weakness. And so S is for slurred speech. So what we can do is we can ask the patient to say a sentence like, "You can't teach an old dog a new trick." So the normal result would be the patient would say or repeat that sentence perfectly and clearly. An abnormal result would be the patient, their speech would be slurred. They might use different words, or they might not be able to speak at all. So if you see any of these signs, T is for time. So it's time to call the emergency services, or it's time to call for help. Even just having one abnormal result out of these 3 tests increases the probability of having stroke up to 70%. It's really important to establish if these symptoms are new. So we need to ask the patient, is this facial droop new to you? Or is this slurred speech new? Or have you always had this? Or have you had this for an extended time? And this is because sometimes the damage from stroke may be permanent. So people may not recover fully after they've had a stroke. Let's talk about some of the other symptoms that might be present when someone has had a stroke. So there would be speech disturbances. So we can have aphasia, which is the inability to speak. We can have dysphasia, the difficulty speaking, and we could have dysarthria. So that's the impairment of the tongue muscles that are essential for speech. The patient may also have sudden confusion or sudden just difficulty understanding, sudden vision changes in either like one eye or both eyes, sudden loss of balance or difficulty with movement or coordination. Also, patients may present with sudden severe headache with no apparent cause. So for instance, subarachnoid hemorrhage, the presentation can be severe new onset headache that the person might describe as a thunderclap headache. It's very important for us to distinguish stroke from other conditions that may mimic stroke. So for instance, altered mental status may mimic some of the symptoms of stroke. Also, like a brain tumor or brain abscess, post-seizure patients, hypoglycemia, some electrolyte imbalances, especially imbalances in the levels of sodium, migraines, and epidural or subdural hematomas as well. Now let's discuss the adult stroke algorithm. So the goal of stroke care is to minimize the brain injury to the patient and to maximize the patient's recovery. It is very, very vital for any bystander or any healthcare professional when they see the first signs of stroke in a patient to be able to activate the emergency response system rapidly. Also, it is very important to note the time that these symptoms first appeared, because that is going to be critical in the evaluation of the patient. That's going to be really, really vital information for either the neurosurgeons or the acute stroke team to assess how much damage has happened in someone's brain. So let's discuss the adult stroke algorithm. So this starts with the immediate general assessment of the patient. So we need to stabilize the patient. We need to take vital signs like blood pressure, heart rate, respiration rate. We need to administer oxygen in case their SpO2 drops below 94%. We need to obtain IV access and get bloods and run any labs that are needed. We need to check for glucose, and we need to treat that if there's any problem, if the person is hypoglycemic. We need to get a 12-lead ECG, And then we need to order emergency CT without contrast. If our CT scan show that there isn't any hemorrhage, then this is probably an acute ischemic stroke. So what we do is we consider fibrinolytic therapy. So we need to check the inclusion and exclusion criteria and make a decision based on that. If the patient is candidate for fibrinolytic therapy, we give the patient TPA. If not, then we can consider aspirin or give the patient aspirin as long as there's no other contraindications. If our CT scan, however, shows hemorrhage, then this is probably a hemorrhagic stroke. So what we need to do is we need to consult a neurosurgeon and admit the patient in a adult stroke unit or in the intensive care unit.